actually does a better job than
Really?
and then I email that note to myself. So I kind of circle around to get it in charge.
But now the dragonfish so special too. It's just one dragon.
Yeah, it works on some words, but there's some words I just can't drag. Word knowledge.
All right, let's go ahead and get started. Told the broadcast is working, but there's always something that doesn't work. Breakfast didn't come this morning. Hard to get there first. But I'm sure we'll get some backup coffee in a little bit. So, Syndey, I don't think will mind if you get up and get yourself a cup of coffee while she's talking. The word of the day is dimista. That's not going to happen again either. I don't know who decided to use it for who paid off who for this.
Thank you.
The suggestion was made that we switch to either nicknames or real names of Seahawk play. So if they don't play better, we can move on to some other teams. Anyway, this is sort of the annual, I find, necessary review of this condition, mast cell biology and mast cell diseases. So thank you.
Good morning, everyone. My name is Syndey Long. I'm one of the second-year Allergy Immunology fellows here at the University of Washington. Today I've been tasked with talking about mast cell biology and mast cell disorders, which has traditionally been Drew's topic. I have no disclosures to make. This is a kind of brief outline of my talk. My goal for this talk is to describe a little bit about mast cells, how they develop, and how they are activated, because that is one of the kind of major cause of the symptoms that we see in mast cell disorders. And then move on to talk briefly or talk broadly about the three different mast cell disorders, namely mastocytosis, monoclonal mast cell activation syndrome, and mast cell activation syndrome. And then lastly, something that I hope will be useful to help the approach to diagnosis. A lot of times these patients come in with symptoms that are vague, and there are, as you will see when I finish the talk, there's not that many objective data that we can gather, so it can be a frustrating experience for both the patient and the provider. So kind of streamlining the approach to diagnosis will be helpful. So as an introduction to mast cells, they were first described by Paul Ehrlich in his doctoral thesis in 1878. He saw them, he noted their unique kind of staining characteristics, saw many granules inside, and incorrectly assumed that they were there to provide kind of supplements to the surrounding tissues. So he named them mastcellen, from the German Mast, meaning fattening. So this kind of roughly translates to feeding cells. The precursor to mast cells are the CD34 positive progenitor cells, are formed in the bone marrow during hematopoiesis, and then it released into the bloodstream where they localize to different tissues and become differentiated based on the local factors there to perform kind of roles more specified to the tissue that they're in. So an important factor in the proliferation, differentiation, and function of mast cells is the stem cell factor, also called the KIT ligand. And this KIT ligand binds to a receptor, a transmembrane tyrosine kinase receptor, the CD117, and this is expressed on mast cell surface, as well as the surface of several different hematopoietic cells as well. The receptor is encoded by the proto-oncogene c-KIT, and as you can see, there are many other factors that have been shown to influence the differentiation of mast cells. These have been shown in vitro, including a lot of type 2 helper T cell cytokines. Most mast cells can be very long-lived, ranging from weeks to months, again depending on the local factors, and they can be found in almost all parts of the body. But their densities have been shown to be highest where the internal and external environments interact because of the role they play in in defending the body against foreign organisms and antigens. So this here is a picture of a human skin mast cell, or mast cell found in human skin. Their morphology can be described as round to spindle-shaped, and you'll note an eccentrically positioned unilobe nuclei here. Cell diameter can be up to 25 micrometers, and kind of their defining characteristic are the numerous large granules here that contain proteases that allow them to affect their function. And granules in mast cells of the skin contain primarily tryptase and kinase, which is probably used here. Here are other pictures of mast cells. These are electron microscopy pictures. On the left, you'll see a mast cell from a human lung tissue, and on the right is a mast cell, again, from the skin. You can see that even though their morphology is a little bit different, you can still identify the unilobe nuclei in both, as well as the granules. It's pretty striking in these pictures. Higher resolution or higher powered views of the granules show that there are some differences based on their, again, location, but most contain the proteases. And I'll talk more about that in a little bit. So what are some of the physiologic roles of mast cells? Like I said, they're important in the defense against bacteria, viruses, as well as some parasites. They play roles in both innate and acquired immunity, and are capable of inducing and, again, amplifying both types of responses. They also have specific surface pattern recognition receptors that allow them to detect microbial products and respond to them individually, independent of the other immune cells. And they can also play roles in recruiting leukocytes, containing bacterial infections, and tissue repair. Some other proposed physiologic roles that are ongoing, mechanisms are not clearly understood, include stimulation of fibroblast proliferation and collagen synthesis. Mast cells have also been noted to be increased within the uterine tissues during pregnancy, suggesting they are playing a role in increasing local immunity and also increasing contractility of the myometrial cells. They may mediate allograft tolerance in mice, and certain proteases have been implicated in blood pressure and intestinal homeostasis. So what are some of their more kind of infamous roles in pathophysiology? They've been noted to play a role in atherosclerosis, found in increased amounts in the plaques within atherosclerotic lesions. Their exact role is unclear, but it's suggested that it's likely to pro-inflammatory cytokines that they release. They play a role in autoimmune diseases, including multiple sclerosis and arthritis. Mast cell deficient mice have been shown to have reduced pathology in those diseases, but upon reconstituting the mast cells, have worsening of those diseases. And then what we are more familiar with are their roles in allergic diseases, anaphylaxis, urticaria, asthma, rhinitis, and atopic dermatitis, and mast cell disorders, which I will go on to talk about. So a little bit about mast cell activation. They are the most known known way that they're activated is through an exposure to an antigen that cross-links the allergen-specific IgE receptor. But they can also be activated by many other triggers that I've listed here, including certain drugs, venoms, and physical stimuli, such as pressure and temperature change. Cytokines and neuropeptides, stem cell factor, and substance P have also been shown to activate mast cells. It looks like coffee is here.
Give us a 1 minute break. Anybody want a cup of coffee?
It's too invigorating.
Well, they asked, it was major revision, they asked a bunch of questions about immunology. So we decided since we had that mast cell receptor, we were doing and unfortunately we're doing it in really piecemeal kind of way. We didn't have a lot of them read it. So we were like doing a couple at a time. We did 6 months, and the first 4 looked like they had the same thing as the 3 steroid responses. The next 2 like didn't do that, and actually everything looked a little funny in those mice. They had a lot of inflammation anyway, hoping to knock back in the wild type. So I don't know if something was
Background noise.
so we're doing another like three with overall, 3 in each group. So we'll see what that looks like. It looks like, and we're doing
So you guys stay down there on
cell
Sunday
dips
to
by
Monday.
flow.
No, Friday.
Or Friday.
They have the same difference in the
Yeah, we do it there.
I'm going to ask Syndey to start again, so just be quiet, because remember, everything's broadcast.
So
Go ahead.
So I was talking about different ways mast cells can be activated. I wanted to say that because emotional stress has been described as a common trigger in patients with systemic mastocytosis, I thought it would be, I wondered about the mechanism, and the proposed mechanism is through corticotropin-releasing hormone, which is secreted under stress, and it's one of the ones listed as a substance that can activate mast cells. So I thought that was interesting. Here is a list of all the different mast cell receptors and their agonists that has been found. I just wanted to highlight that the KIT receptor, tyrosine kinase, is the one I was describing earlier. That's the main one responsible for the progress of the mast cell differentiation and activation. So here is a list of mediators that can lead to the granulation and secretion of the granules in mast cells. Histamine. Oh, sorry, I apologize. These are what is released when the mast cell is activated. So histamine obviously is an important one. Other mediators include serotonins, proteases, leukotrienes, prostaglandins, platelet activating factor, and several cytokines and chemokines that lead to T cell activation. Here is a thorough list of the mediators. Just wanted to highlight the histamine and its pathophysiologic effects, notably vasodilatation, leading to hypotension. Here is tryptase, leading to inflammation, and prostaglandin D2, which can contribute to bronchoconstriction. So those are the ones that I will focus on a little bit in the rest of the talk. Here is a good diagram I found in the New England Journal of Medicine that kind of summarizes what I just described, including the mast cell activators that can lead to degranulation of the mast cells. Here are the mediators that lead to the clinical presentation that we see in patients with mast cell disorders. As you can see, it covers most of the organ system, and for this reason, makes it difficult to identify a clear, obvious way to diagnose patients, especially based on symptoms alone. I found a interesting video that showed the activation of mast cells. I'm just gonna see if I can pull it up. This is from New England Journal of Medicine. Maybe. Those are all the granules being released after they're activated. That was pretty cool. So this is one human mast cell they were able to isolate between two cover slips, and they use substance P, which is a neurotransmitter, to activate. All right, now moving on to mast cell disorders. So when we think about mast cell disorders, it's good to divide them up into 3 groups. And this table that I found in UpToDate is helpful to kind of organize thinking about mast cell disorders. And Drew and I have actually used this table to explain to patients, and I found that is helpful because we can identify which conditions are concerning for the patient, as well as conditions that are with better prognosis, essentially. So the first category are the primary mast cell disorders, and that includes the systemic and cutaneous mastocytosis, as well as monoclonal mast cell activation syndrome. Essentially, these disorders include clonal populations of mast cells that arise from an affected progenitor. They have intrinsic defects in their proliferation and activation pathways, as well as abnormal genetic and surface markers. And bone marrow biopsy is really the only way to diagnose primary mast cell disorders. The second category is, or the secondary mast cell disorders, have normal quantity and function of the mast cells. They are responding to external stimuli such as allergen, autoantibody, drug, and the categories include allergic diseases, which can include obviously the IgE-mediated food, drug, allergies, as well as other allergens. Physical urticarias are also grouped under here. Autoimmune urticaria and neoplastic and hematologic conditions that, and chronic inflammatory conditions that can lead to mast cell activations are here as well. And then the last category is idiopathic. And as you all know, that's just what we call things that we don't know a cause for. And that mast cell activation syndrome is one of the disorders listed here. And again, it's possible that these could be primary and or secondary if eventually genetic defects are found or their stimuli are identified. But at this point, they are just kind of a group all things that we don't know the mechanisms for. And these are the 3 this is a good table that I will refer back to as I go on to talk about the different mast cell conditions. In comparing systemic mastocytosis, the monoclonal mast cell activation syndrome, and just mast cell activation syndrome. This year it's idiopathic anaphylaxis. Here are some of the conditions that we look at, some of the signs and symptoms, and I will highlight the differences that will allow them to be differentiated, essentially. So starting with this first one, mastocytosis. It's a disorder that's characterized by excessive mast cell accumulation in one or multiple tissues. It can be divided into two subgroups, cutaneous mastocytosis, which is limited to the skin without other organ system involvement, and systemic, which shows pathologic mast cells in multiple extracutaneous organs. And in the systemic category, you can have skin involvement, but it's not necessary. And the symptoms and effects that you see the patients have in mastocytosis result from, again, the mast cell activation, mediator release, as well as just the accumulation of mast cell itself in the organs. So this is the tyrosine kinase receptor that binds to stem cell factor, which is the cytokine that's involved in their proliferation and differentiation. It is encoded by c-KIT, which is localized to chromosome 4, and this will be important when we talk about the kind of mutation that leads to this disease. It is, like I said, it's expressed on a variety of hematopoietic stem cells, including the mast cells. But the difference is that mast cells continue to express this throughout their lifetime, the lifetime of the cell, unlike most other cells, where once they've matured, they are not as affected by the stem cell factor anymore. This here is a schematic of the activation of the tyrosine kinase receptor, the KIT receptor, which leads to phosphorylation and many kind of downstream effects, ultimately leading to their to regulation of mast cells and their cytokine production. So one of the most so there are several different mutations that can lead to the disease. The most common one, and this has been seen in greater than 95% of patients with systemic mastocytosis, is the aspartic acid to valine mutation, D816V. This causes them to essentially autophosphorylate independent of lichen binding, and activates the mast cells without external stimuli. So they gain a function. Here are some of the symptoms that you can see in patients with mastocytosis. Again, most of these are due to the mast cell mediators. And like I showed in that first schematic, there are many symptoms, but these have been the ones that are more, I guess, less, I mean, even though they seem pretty non-specific, or more specific than the others, which, included headache and fatigue, things like that. So you would look for, inquire about bronchoconstriction, syncope or pre-syncope due to reduced blood pressure, and focusing on skin symptoms and GI symptoms with pruritus, urticaria, and angioedema, abdominal pain, nausea, and vomiting. Flushing is also a big one that we see. And then you can also, symptoms also can be from, like I said, the infiltration of mast cells into the organ tissues themselves. If infiltration in the bone marrow leads to anemia, thrombocytopenia, lytic bone lesions, and then in other organs can lead to hypersplenism and hepatomegaly. This is a picture of cutaneous nodular mastocytosis. Lesions are just found in this infant toddler. And then one thing to look out for is the presence of urticaria pigmentosa. These are small yellow, tan to reddish lesions that are found all over the bodies of patients with mastocytosis, most commonly in the upper and lower extremities. And it is actually an important, let's see if I can, it's actually an important differentiation that you see, that you can use to differentiate between mastocytosis as well as monoclonal mast activation disease. Patients with mastocytosis.
Could you speak up? I've got a comment here. People can't hear you well. I don't know if that is the microphone or the ones in the ceiling, but just talk,
Okay.
shout.
So urticaria pigmentosa is one of the risk factors that differentiate between the mastocytosis as well as monoclonal mast activation disease. It can be present, but not necessary to diagnose it for mast cell, but it's not present in monoclonal mast activation disease, as well as the other diseases. So the presence of it, really points you towards mastocytosis. Also wanted to bring up derriere sign, which is the development of localized urticaria and erythema at the site after a lesion is rubbed or scratched. And this is due to actually physical irritation of mast cells and leading them to release inflammatory mediators. Here is the official World Health Organization criteria for diagnosing systemic mastocytosis. You have to have one major and one minor, or 3 major criteria to qualify or to be diagnosed. The major criteria is the finding of multifocal compact infiltrates of mast cells in bone marrow or other extracutaneous organs. And then the minor criteria include finding abnormal morphology in mast cells in bone marrow or other organs, finding evidence of c-KIT mutation that I described earlier, and this is generally in the bone marrow or other organs, not generally in the serum. And then other surface markers include CD2 and CD25. And then lastly, a serum tryptase level of greater than 20. It's also one of the minor criteria. And as you can see, most of these criteria require bone marrow biopsy to diagnose. The only thing that we really have that we can use in clinic is the tryptase level. There are several different categories or several different groups of systemic mastocytosis, and they differ really only in their essentially involvement of other systems and prognosis. So the indolent systemic mastocytosis is the most common form, and this one has a decent prognosis with stable, only slowly progressing clinical course. It's normal life expectancy and rare leukemic transformation. If the c-KIT mutation is found in all cell lineages, there is an increased risk of progression. The second category is systemic mastocytosis with an associated hematological non-mast cell lineage disorder, and it's just as it's described. And the prognosis is poor with median survival of about 2 years, and depends really on the related hematologic disorder. The last 2 categories are aggressive systemic mastocytosis, which is rare, found in 10% of patients. And this is defined as having one or more see findings that include hepatic fibrosis, portal hypertension, malabsorption, or cytopenias due to the actual tissue infiltration of the mast cells. Again, this one has poor prognosis. And then lastly is the mast cell leukemia, which requires the presence of greater than 10% mature mast cells in the peripheral blood or greater than 20% of immature mast cells in bone marrow smears. This one has the worst prognosis with a median survival of less than 1 year. Here is staining of mast cells in bone marrow. The first picture shows staining with anti-CD25, which is one of the surface markers that they look for in diagnosing one of the minor criteria. And here is anti-tryptase antibody staining. Here is just another picture of urticaria pigmentosa with pictures of mast cells that can be found in the skin biopsies. So to summarize systemic mastocytosis, generally, so you have the mast cell aggregates. This is a major criteria, and then the minor criteria with the c-KIT mutation, aberrant CD25. That's the other surface marker. Urticaria pigmentosa, which may or may not be present, and baseline tryptase, which is usually elevated. And then we'll look at monoclonal mast cell activation syndrome, which really you see the difference is lack of mast cell aggregates in the bone marrow biopsy, and then lack of urticaria pigmentosa. Baseline tryptase may be increased, but it's not necessary. So, like I just described, it's essentially having all the symptoms of mast cell disease, or systemic mastocytosis, affecting 2 or more organs, but without the kind of bone marrow biopsy findings of the mast cell aggregates. They do, however, have the c-KIT mutations or other, the rare mutations, and the CD25 abnormality. Important to note that they lack urticaria pigmentosa and the bone marrow findings. So, what if a patient has clinical presentation of mast cell disease, but does not meet any of the criteria for the primary mast cell disorder? And here is kind of where we fall into the vague evaluation, where it's harder to kind of fully define because of the lack of kind of objective data that's available to diagnose it. And this would be the mast cell activation syndrome category. So baseline tryptase might be normal or mildly increased, and then everything else is essentially negative. So mast cell activation syndrome, this disorder of mast cell hyperreactivity was proposed by an international group in 2010-2011, where, like I said, they had these groups of patients who have all these symptoms but don't have the evidence of kind of mast cell disorders that you see, mast cell abnormalities that you see in mastocytosis and the monoclonal mast cell disease. So they've identified possible triggers in these patients, including drugs, physical factors, surgery. Alcohol has been a big one that I've seen in clinic, infection, emotional stress, and toxic exposure as well as ethane. Here is their criteria for mast cell activation syndrome. You have to have, well, this is the official criteria. Let me just summarize it for you here. Essentially, mast cell mediated symptoms affecting 2 or more organs. Second criteria is an improvement with treatment, either with histamine blockers or leukotriene blockers or any of the blockers of their mediators. And then 3, most importantly, that we can, because the first 2 are rather are subjective. 3 would be to have evidence of an increased activation marker. Most commonly used is tryptase, and they give a level of greater than 15. Documentation of increase above baseline during a symptomatic period is also possible. And the value that we've used, which has been shown in literature looking at episodes caused by bee stings, is 1.2 times the baseline plus 2. And I'll have that in a later slide. And then lastly, of course, this is almost a diagnosis of exclusion. Rule out other causes. Here is a list of conditions that can mimic mast cell disorders that we should keep in mind when evaluating patients with this disease. Again, it involves all the systems, and it's very it's not as helpful. Things that by the time a patient comes to see us, they likely would have been evaluated by other specialists, which would with data that can rule out a lot of these disorders. The ones that we should focus on are the ones that might not have been evaluated and present with symptoms that are consistent with mast cell disease. Pheochromocytoma with episodic flushing and episodes of hypertension. And on the right are kind of workup that we can do. Carcinoid with flushing, diarrhea, hereditary angioedema, VIP secreting tumors, and Zollinger-Ellison syndrome.
I'm going to interrupt you here for a second. Drew, I know you've dealt with a lot of people with this, and this is really a squirrely diagnosis. In your experience, what would you say about this? Are there people who really have this?
Oh yeah, you can document the elevation in tryptase, and then I try and use those firm criteria and get as much objective data as possible. I also have most of them that come in to see me, I can't diagnose the increase in tryptase during an episode, but I always go through that with them and also go through the differential diagnosis and try and stay as objective as possible. It's a challenging patient population.
Seems to me we always list pheochromocytoma, but the blood pressure is the opposite direction. People should have hypotension, not hypertension. I don't know how that one gets confused with this situation.
I think it's because of the episodic symptoms that they have. They'll have headaches and they'll have flushing.
Or somebody has to check the blood pressure when that happens.
Do you normally order all of these things when you have someone with these symptoms? You look for the PO and stuff like that. I mean, do you?
Only if the history fits. If I see an elevation in their blood pressure and an ER note or something like that. No, I try and go through their symptoms. HAE doesn't really present like this, so I rarely work that up. And, occasionally, but you have to go by their symptoms, whether they're having mainly GI symptoms, hypertension, things like that. So it's not a routine workup.
The other thing that's always a problem clinically is people who come in with foggy brain or CNS type syndromes, which supposedly are a legitimate part of this syndrome, if you have all the other diagnostic criteria. And it's interesting that stress, which also plays a role in this, may actually be a stimulating factor, but I don't know how you feel, Drew. Those things are near impossible to evaluate and feel comfortable about your diagnosis.
Very challenging. In the clonal mast cell patients, they really do describe that brain fog, and it's well documented. And the mast cell activation syndrome, who knows?
Maybe it's for both of you. Adrian. Adrian is a model of a mouse model with the knockouts.
Mm-hmm.
And they see some abnormalities in the coagulation pathway, increased bleeding when you knock out the mast cells. So do you see any problem the other way around? Do you know about increased risk for thromboembolic events in mast cell activation?
No, I haven't.
Repeat David's question for the outside audience.
Is there an increase in thrombotic events in these patients? Just because Adrian Piliponsky, who works at the Children's, is a leading mast cell researcher. No, I haven't, but I haven't really been looking.
Mm-hmm.
I probably have 20 mastocytosis patients. That hasn't been an issue that I've seen in any of them, but I haven't been looking.
So one thing I can say, I've seen a handful of mast activation patients, or patients being worked up for mast activation syndrome, and one or two patients with mastocytosis. The ones that have the disease, they have more kind of discrete episodes that they can describe with acute symptoms, whereas the other ones are less discrete and kind of more chronic, vague symptoms. Another thing is, by the time they come to us, by the time mast activation syndrome is like on their differential, they've likely been worked up by many other specialists, and like over a course of years. Like I've seen patients come in or worked up when they've had symptoms for 20 years. So it's I feel less. I feel more confident that they've been ruled out for a lot of the other dangerous things, and then we can go on to investigate.
Didn't some of the first descriptions of this come out of a second-rate institution, the Brigham?
From a Harvard.
All right. So what can we do for diagnosis? So getting a thorough history, asking for all of the symptoms that they can present with, which can take a little bit of time, and making sure that, seeing if they have symptoms that affect at least two organ systems. What to look for in an exam, helpful findings would be urticaria pigmentosa. See if they have pictures of it. Always asking for pictures of skin findings or angioedema or anything like that they might have taken during acute episodes. Hepatosplenomegaly, abdominal exam. Labs that we can get. Tryptase, like I said, is the most specific of the mast cell activation conditions that we have currently available. Things that people have also looked at include histamine in the plasma. You can also look at histamine in the urine, but that's not as specific. There are difficulties in obtaining these as well due to their short half-life. And I'll talk about the prostaglandin and the urine histamine later when I look at an article that compared their efficacy in diagnosing mast activation syndrome. So here's one kind of proposed approach to diagnosis. You have a patient coming in with unclear signs and symptoms, describing kind of recurrent anaphylaxis or recurrent episodes of these symptoms. Look for urticaria pigmentosa, so that's easily found, and if it's present, can lead you to a diagnosis of mastocytosis. If it's not present, consider measuring their baseline tryptase. And if it's greater than 20, meet some of the minor criteria, they warrant a bone marrow biopsy. And obviously, if they fit, it's diagnosed. If it doesn't meet through, if there's no aggregates, essentially, mast cell aggregates here, but they do have clonal markers on their mast cells through the biopsy, they are monoclonal mast cell activation syndrome. If they don't have any evidence of clonal markers, you go back here, where you would have ended up if they didn't have elevated tryptase, but still had these concerning symptoms of presyncope, syncope, or hypotension. And this is when you would ask them to give them a lab slip to measure their tryptase level when they have an acute episode. And other ones to consider are, like I said, the urine histamine and the urine prostaglandins. If it's normal, it's likely not related to mast cells. But if it's elevated, it's possible to be mast cell activation disorder, if they have a response to antihistamine treatment, anti-mediator treatment, which is the second criteria. So this is really confusing, but we'll try to streamline it for kind of faster, more efficient approach in clinic. After I kind of review an article here. Like I said, tryptase is the only objective data we can measure in clinic. Otherwise, we would send them to bone marrow biopsy. So our kind of branching point is who to send to bone marrow biopsy.
Can you order tryptase in our system easily? We one time tried to order that when we had someone with exercise-induced anaphylaxis, and it seemed like the lab wasn't really set up for that.
No, it's, yes,
That
standard.
was a few years ago.
Yeah, it's very standardized now. They're actually going to run it in-house at some point.
Oh,
Sometime early 2016 is what they were promised.
all right.
In case anybody didn't hear outside, the question was, can you readily get tryptase levels? And the answer is yes.
That's also helpful for, a lot of times, like when we're dealing with inpatient consults, patients with anaphylaxis symptoms, the residents are not kind of aware of the tryptase, how tryptase can be helpful. So getting it within kind of like 3 to 4 hours after the acute episode is the most helpful. So that's something we can try to kind of educate the residents on.
In different papers you see different levels. You commonly see 11.4. Above that, I'm just wondering where these numbers come from. You've been talking here about greater than 20. And then there's another one that confounds me, 1.2 times the baseline plus 2. Is that right, Drew?
That's from mast cell activation syndrome.
So where do all these different cut points come from? Anyone?
The 11.5 is, I think, 95% of normal patients. That's like, in a study, I think they looked at like 126 patients. And in patients with, that's kind of the normal range, less than 11.5. And then the greater than 20, I'm not aware of the kind of specific study, but that's for diagnosing mastocytosis. And then the in-between is where we have like the monoclonal mast cell activation syndrome and then the mast cell activation syndrome itself.
15 is a cutoff they use in the REMA score, that group out of Spain that I often use. Just the likelihood, pretest likelihood of having a clonal mast cell disorder. So yeah, there's a lot of different numbers out there. It kind of goes into which biopsy or what you're looking for, basically, whether you're looking for clonal disease versus mast cell activation syndrome.
So that's the most nebulous one, mast cell activation
The
syndrome.
idiopathic.
Yeah. So what do you use as a mean? Because that's what it all comes down to, really, in that diagnosis. Everything else is subject to what number do you look for in mast cell activation
I get a
syndrome?
baseline if it's above 15. It's more concerning, obviously, for clonal disease, and I'll often send them for biopsy. But I use the tryptase in the setting of an event, the 1.2 times baseline plus 2. So I always get a baseline, send them out with a lab slip to tell them to get a level drawn when they have an episode.
Yep, I'll actually talk about the REMA score paper here. Because, as Dr. Alman pointed out, it's a difficult diagnosis to make. So in this paper out of Spain, 2010, they look at, they try to see if they can identify factors that will predict, clonal disease versus mast activation syndrome. So their objectives was to look at patients with mast activation symptoms in the absence of skin disease to see if they could predict, again, where they belong. This will be helpful for determining who to send for bone marrow biopsy. So they looked at a total of 83 patients. They did bone marrow biopsy in all of them, molecular studies to determine what group they fall into. And there were two different groups. The systemic mastocytosis, where they had 48 patients in this group. This is the monoclonal mast activation syndrome patients. They had clonal disease, but they had abnormal markers, but no evidence of mast cell activation on bone marrow biopsy. And then the last group is our mast cell activation syndrome patients with negative bone marrow biopsy. They compared mainly the mast cell activation disease patients with the systemic mastocytosis patients. They looked at a lot of different things, demographics, age of onset and diagnosis, symptoms that we talked about, and then a lot of biochemical markers. They got CBC, CMPs, IgEs, tryptases, even vitamin levels, to to see if they can, identify markers that can be helpful. What they found was that so the dark bars are the mastocytosis patients, and the lighter bars are the mast activation diseases. And these, up to syncope, up to hypotension, up to hypotension is where are the differences in the symptoms. They saw that urticaria, angioedema, and dyspnea were significant. The differences between the two groups were significant. And then pre-syncope, syncope were more noted in patients with mastocytosis. So, this is helpful to kind of guide us one way or the other. They did statistical analysis, and the top table shows clinical and laboratory variables that are associated with clonal mast cell diseases, and the bottom one shows variables that are associated with non-clonal mast cell diseases, just the mast activation syndrome, essentially. And they, they had pretty good significance there. So they were able to use all of this data to formulate a scoring model to use as a screening tool to determine whether a patient, to determine the probability of clonal versus non-clonal mast cell disease, i.e. whether you should send them to bone marrow biopsy or not, essentially. So they would look at gender, clinical symptoms, and tryptase level. So you get actually a point for being male, minus point being female. Urticaria and angioedema, like we saw in the chart or in the graph, was more associated with mast activation syndrome. So you actually, absence of it gives you a positive point. Presence of it gives you negative 2 points. And then pre-syncope and syncope gives you 3 points. And then the tryptase level here, they use less than 15, less likely clonal disease. Greater than 25 is more likely clonal disease. And here is the score, gives you the probability. So 2 is kind of the cutoff point.
So Syndey, I'm guessing that levels between 15 and 25 are indeterminate. I mean, they could go either way.
Yeah, I think that would be like a 0.
And those values are during an episode or random?
Baseline.
Random.
Right.
So sensitivity and specificity that they found were pretty good in this study. So how to incorporate that into this very confusing approach here? What Drew and I have done in clinic whenever we see a patient is, so a patient comes in, has symptoms consistent with mast cell disease. If they have a tryptase greater than 20, particularly if they have it greater than 20 on 2 occasions, send them to bone marrow biopsy or consider it. This is because of the cutoff for the mastocytosis. If their tryptase is less than 20, baseline tryptase is less than 20, employ the REMA score that we just looked at, rate them, or score them on that model, and if they have a score of greater than 2, greater than or equal to 2, there's a high probability of clonal disease. Send them to biopsy. If it's less than 2, this is where we get a baseline tryptase. Obviously, that's done up there, and then give them a lab slip to measure tryptase within 3 hours, ideally, of an event. And then the tryptase level that we were talking about earlier, 1.2 times their baseline tryptase plus 2, will qualify them for mast cell activation syndrome. This is during an acute episode. So this is kind of what we try to use in clinic based on the things that we can easily do. Like I said, bone marrow biopsy or a tryptase. So not many options for
The only slight disagreement would be what the key word is what are the symptoms? Because if you look at the last paper, if there's really not signs of syncope, and it's a male, and they just have angioedema, and their tryptase is over 20, you wouldn't do a bone marrow biopsy. And I've got 3 of those patients. 2 of them finally demanded to get one, and indeed they had nothing on their bone marrow biopsy. So the key part of the other algorithm that you showed is signs of actual, syncope, etc., which is different than all of the others.
Yeah.
So it's even more confusing.
Yeah, so you can use this one or more official one.
Right. See, the top part is the, really signs of anaphylaxis, whereas some of these others can be a little more non-specific.
So, Syndey, even if you take them the bone marrow biopsy, whether they're positive or negative, is any of this going to change how you treat them?
In terms of evaluation, in terms of screening and follow-up?
No, just how are you going to treat these people? Because,
Really.
it seems like you get a bone marrow biopsy whether you want one or not, and if it's negative, you're still going to treat them, and if it's positive, you're still going to treat them.
Some you need to send to psychiatrists.
That was my next question. So if it's negative, do you offload them?
You can go with it.
Unfortunately, there are not curative treatment options for mastocytosis. There are rare cases of if they find a specific mutation, like the mutation that I said was most common was the D816, B. That one is not responsive to imatinib, which is the one drug that they consider because it's tyrosine kinase receptor. But if it's not that mutation, that has been used with some degree of success. But because it's so rare that patients have this disorder, and it's not that mutation, it's not a big impact in terms of patients.
That's a fair question. It's the same with doing the urines if you're going to put them on high-dose mediator blockers anyway.
These are the people I try and talk into doxepin because I give mediator blockers and treat their craziness at the same time.
That's right.
And it works pretty well, actually, if they'll take it. So.
I think it's essentially symptomatic treatment, but if they do have a diagnosis, it would warrant kind of closer follow-up, and because of the possibility of progression and these several different of the mastocytosis subtypes I was talking about with poor prognosis.
They have some bearing on who you give EpiPens to. If you think they have real disease, they should have it. We've probably all seen people who repeatedly give themselves EpiPen or epinephrine injections who don't have real disease. That worries me. I've seen people give themselves 3 EpiPens in a day or something like that for non-disease. You're going to comment about the overlap, the issue here with venom anaphylaxis and these conditions, people we see, rare people with negative skin tests for venoms and yet true venom anaphylaxis.
I'm not going to talk about that specifically, but they have shown, like in the last paper, they looked at the triggers for the symptoms. I didn't include a slide about that. The patients with true mastocytosis have, venom is a very common trigger, more so than in the other patients.
Just maybe to comment for our 2 newest fellows, this is a unique issue locally that we kind of learned the hard way from the tragic outcome that you can see people with a convincing venom history and skin test negative to venoms. And at the time it wasn't known, but you may well have an underlying mast cell disorder and misdiagnose it and say we don't have venom anaphylaxis, and yet people do. You can have venom anaphylaxis, perhaps an underlying mast cell disorder, and be skin test negative to venoms and be at risk of life-threatening anaphylaxis.
I'm going to leave, but I just want to, this has nothing to do with this talk, but you did a nice job. Do you guys all know that Hans Ochs's son died in a surfing accident? Just FYI, I think they're supposed to have a...
Just recently?
Just recently, it was in the...
Yeah, there's a nice obituary in the, if you can say nice with obituary, in the Times.
Yeah,
If you just Google Oliver Ochs.
Yeah, his name, and he was an interventional radiologist.
Memorial sometime later
So
this month.
I just wanted people to, just if you see Hans. Alright, I'm bored.
All right, I think I'm out of time. treatment setting.
Oh, I should